Now you see everything is together. So know the anatomy of the anal spaces, and this is the anal space. We know this. The supralevator is a problem, but oh no, even in this is ये तुम्हारा 16/9 को change हुआ है इसलिए problem आ रहा है. Okay, we'll just go ahead. And this is going to happen with everything. So we have already talked about this in the morning. So you have these spaces, and these spaces are where the abscess are: intersphincteric, extrasphincteric, and supralevator. We need to know, and more than one space can be involved. It can be all three spaces also. So the progress of sepsis starts actually here, and this is when the patient comes to you, and we treat it like a anal fissure, because the patient has pain, and the pain is mostly in the midline posteriorly, and we presume it's a pain of this. But when you do a PR examination, it's not, the spasm is not there, but the pain is there. Spasm is missing, which is of anal fissure, but the pain, tenderness, specific tenderness. Get an MRI done, and this abscess keeps traveling. Know the route of anal abscess spread. So it spreads vertically, and when it spreads vertically, it goes to different planes. So here you have intersphincteric abscess, which can go up and can go down. When it goes up, rectal, rectoperitoneum, anterior abdominal wall, and it can go transsphincteric, it can go up and it can go down. So these are the problems we are facing, and we think, okay, we know everything about it. But then there's a horizontal spread, and because of horizontal, we have a horseshoe. So the problem is here, it's going all across. There's nothing to stop it. So an abscess from here can go to the other side, and this is a posterior horseshoe abscess and can extend further up, and that causes a lot of problems. Posterior anal abscess extensions, low posterior transsphincteric abscess can be there, or a high deep posterior abscess can be there, which is below the supralevator and above the ligament or anococcygeal ligament. And if we don't take care of these abscesses which are behind, they're never going to go away. And this one I've already shown you in the previous picture. This is the path of abscess drainage and causing a lot of problems. It can come to the abdominal wall, as you see here. It can go to the leg. And don't manage the abdominal wall and the leg aggressively. Just curate it. What you need to manage is the primary problem, that is the anal canal. So in the male perineum, you have to remember there is no external anal sphincter or puborectalis there. And when you see openings in the scrotum, we presume it's opening at 12 o'clock. Be very careful. Some of them open at 12 and some of them open at 6 o'clock. So you have to have an MRI to know where it's actually your internal opening is. And in the female perineum, remember, you have retrovaginal fistulas, Bartholin abscess, and incontinence has less muscle mass there, so you have to be more careful. MRI has to be done in an abscess. If it's a perineal abscess, okay. But if you feel anything inside above that, above the dentate line, then you need an abscess. When do you do it? When it's not a cryptograndicular abdominal source, post-infection, post-incision drainage, suspected supralevator, multiple space abscess, horseshoe abscess, occult abscess, and inadequate physical examination, because the patient has so much pain they're not letting you see. So you have to look for the fistula tract. Remember, each abscess has a fistula. It's up to you to find it. It's up to you, the radiologist, to find it. So here, what you see, abscess is there, and you see the fistula tract. So all abscesses, how did the abscess go there? It starts in the internal opening, it starts in the intersphincteric space, and the abscess is going to other planes. How did it get there? There is a road through which it went, and that road is the fistula tract. So fistulogram, when you do, you need several things. If you have a phone and if you have Google, take this QR code and take a picture of it on Google, okay? And see the report which comes. The report you see on the right side is the report you get on your phone. And you can scroll through all the 500 pictures and you can zoom it, and the report is there. Every angle is given, every weightage is given, and this is what the MRI should do. This MRI will cost the same cost that MRI costs in your city. The radiologist is not ready to do. So I have to have a report with a QR code which comes on my mobile. They have to draw a picture and they have to give a glamour film. So my patient comes with one single film. One single film has 6 pictures or 8 pictures which has label. where the internal opening is, where the external opening is, and if the radiologist doesn't do it, you change your radiologist. Send everything to the same radiologist, and they will change. This is the same cost as you are doing. The radiologists don't want to take that extra step. Remember, all MRIs are not the same. They can be done the same, but the guy who reads the report should know about the fistula. Drainage is the mainstay. There's no role of conservative management, and it's sad to see physicians and general practitioners and even gynecologists keep giving antibiotics in abscesses. Antibiotics, you don't really need it. Maybe one dose pre-op, you've drained it. Why do you keep giving antibiotics for a couple of months? Culture, you don't need to give culture. Now, have you not experienced that you've done the culture, you never see the report. You started the antibiotics. Patient comes with the report after 3 days. Chalu kiya hua hai. The same thing has to go on. You don't need a culture. This is literature proof, not mine. It's in the literature. You don't need to do a culture. Don't wait for fluctuations. Needle aspiration, confirm, and then drain. So in a normal abscess, what we do is we just drain it. But if you are going to drain it by aspiration, do it as close to the anal canal as possible, and put a few drops of methylene blue, 1 cc of methylene blue and a few drops of hydrogen peroxide, and that will show you where the internal opening is. Nothing could be seen here. Inside, nothing was there. I just aspirated a few cc of pus, put in 1 cc of methylene blue, and it comes in from the internal opening and did a primary fistulotomy. So rates of recurrent is when 2.8% primary fistulotomy. Vice versa, if you just incise, is 40%. Correct anal abscess drainage prevents a fistula formation. So each abscess has a fistula tract. You see this green? So you need to do the right way. Now these pictures are an exam for you. What are you going to do in these patients with abscesses? Skeletal muscle rule, do you drain inside or do you drain outside? You have to abide by it. So the skeletal muscle rule says the external anal sphincter is the muscle you have to think of. Abscesses which are medial to the external anal sphincter and do not cross the external anal sphincter have to be drained inside the anal canal. Anything which crosses the external anal sphincter, you have to drain them outside and inside both. Locating the internal opening. Now, abscess drainage with simultaneous fistulotomy can be done only when you can locate the internal opening. 30 to 70% patients with abscess have you can do a primary fistulotomy. But remember, when you are doing the fistulotomy, the biggest hurdle occurs is when you are probing the tract. In effort to find the fistula opening, internal opening, you can cause false tracts. Now this patient has 1 external opening and 3 internal opening. So in the abscess, the surgeon probed, and the probe is wrongly probed because you are angling the probe towards internal ischiorectal ring rather than angling towards the dentate line. So wrong probe, and outside there was only 1 opening and inside there were 3 openings. If the internal opening is seen, you have 2 choices. Choice number 1, primary fistulotomy, if you are experienced. Choice number 2 is sit-on. When do you put sit-on? When the amount of muscle you feel over the probe is a lot and you don't want to sacrifice that much muscle. It's more than 30%. It's best to put a sit-on in and wait. So, how much muscle can be sacrificed? Anteriorly in females, nil. Posteriorly 30%, anteriorly 30%, posteriorly 50% in males. But remember, if you are sacrificing it and if you are closing it, you can go higher. Ischiorectal abscess, primary fistulotomy avoids a subsequent fistula. So you have done it, you've cut down, and you opened this. You don't need to make a big incision, just that much, and curate everything else. The abscess in the ischiorectal fossa is just the collection point. There is no infection there. It's just collecting there. The problem is here. So you have already cut down from here. You have taken care of the internal opening, and then you just cut this much. So these are 2 patients. Simultaneously, the video will go. The one on your left side is a young teacher with abscess, and the one on the right is an abscess at 7 o'clock. The left one, I just make a small incision of about 2 centimeters. As soon as the pus comes out, I will stop. And for the rest of the cavity, I will just cure it. I've done the primary fistulotomy. I've opened up the tract. I've taken care of the central disease, and the rest I just leave it open. And on the right side, you have a abscess in which primary fistulotomy was done. And post-op, this is day 5. A big abscess like that. Preventing incontinence, you do have to do a primary fistulotomy and then do a sphincter repair. So what you do is you excise the internal opening, you curate the abscess or cut it out, and you ligate or take a suture over the external opening and marsupialize the internal opening area. Don't close it. So large ischiorectal abscess, this is how it was. And see the angle of the tract is very high. That's how it was. It looked simple, obviously. So I mark all the abscesses from outside, and what I'm looking at, the internal opening I can see, that's where it is. Then I aspirate it, I know where it is, put in methylene blue. Obviously it's going to come there, so stop. Then I give saline adrenaline. Saline adrenaline is made by taking 100 ml of saline and putting 1 ampule of adrenaline in it. And then I start and dissect and excise the internal opening. This is called excision of the central disease. Once you have taken this out, you are sure this is not going to recur because the source of infection has been taken care of. And you can lift the mucosa and go underneath it. The tract was going high, so I'm lifting the mucosa and going below it. You saw the angulation, it was high. So the tract goes up to the external sphincter as high as possible, and because the tract is fibrosed, you can go. It may come out in pieces, and see, I'm still with the tract. The mucosa is elevated by a small right angle, and keep following the fistula tract. And it's simple. You need just 2 cat paws, pull it down and pull it up, and it keeps going up. And that's the tract, whole tract which has come out. And then I go to a point which is just outside the external sphincter, curate everything. I put a warp scope inside and I saw everything. I knew it would not be possible to do it. Excise the muscle. And after you excise the muscle, curate it well. Put the scope inside to see for any of the problem. And there were a lot of slough inside. And I also put the scope inside the anal canal, and everything was okay. And then you do a primary sphincter repair and come out. It took 1 month and the patient was completely healed. So these were the steps. You have the abscess, you have seen it, you have cut it out, and after excising it, you do the primary fistulotomy. And this is Dr. Kamal's video. Is showing you the same thing with the abscess located at 6 o'clock position on the other side. And after draining it, the principle I'm trying to tell you, excise the internal opening. So after knowing everything, the first thing he will do is excise the internal opening here. He's taken that out, and what tract is left, you excise. And after you've excised it, you suture it. And don't close the skin, leave it like that. There was an abscess going very high, a counter incision was done, nothing else was done, curating, and just put a ceton there. This is the infant feeding tube ceton. And this is the primary using 20 PDS. You're closing the external anal sphincter. Internal sphincter doesn't need to be closed, just close the external sphincter. Okay. You can do the same thing for the anterior fistulas. You inject in hydrogen peroxide, you make a small incision, you drain it after probing it, and after cutting it, you know you have cut it, but you still have to take the excise the central opening which is inside. And once you have done that, whole tract is clear, and curate it, and then close it. This is excision of the central disease, where the whole problem is, which if left behind, there's going to be a recurrence. And then do a primary sphincter repair. Most abscesses can be managed by primary fistulotomy. Now, if you think it's too high, you just place a seat on. Don't do anything, just place a seat on, but don't make a false tract when you're doing it. So, anterior female, I was doing it. I wanted to do a primary fistulotomy, but I felt the amount of muscle was too much, and I didn't want to take that risk. So I put in a draining seton after having managed the whole tract. So in this, I clean everything, put the scope inside, wash everything, then put a seton, and after 3 weeks, it had come down quite a bit, and in local anesthesia in the OPD, I excised it. Now, internal opening is not there. What are you going to do? You can do a tube drainage, or you can do a Foley's drainage. So, this is even though it was intersphincteric, I couldn't find the internal opening where it was starting, so I just put a tube in. So you see the abscess, you put in methylene blue, you take an incision, you drain it, you curate it, you wash it, put the scope inside and see it. The part of my talk is minimally invasive, and just put a new drain inside and they're going to heal. So what I'm saying is catheter drainage, tube drainage or seton can be applied. So similarly here for this patient, both infiltrating tube and tube, because the amount of muscle involved was about 75%. So no cruciate incision. If you're still giving cruciate incision, you shouldn't. This incision should be banned. If you want to just drain it, the drainage size should be 5 mm. Put the curate inside, not your finger. Curate everything out, wash everything, use 1 liter of saline and put a drain. Foley's will work well. Foley's will come out on its own, inflate only 5 cc, and a few days time when the cavity collapses, it presses and it comes out on its own. Cruciate incision is a complete no-no. Now, this is people making cruciate incision or big incision, and this is the result. See this patient, big incision, but he's come back with a recurrence. Here, you've already seen that. This patient, big incision going to the scrotum, and he's come back with an abscess again. So large incision is not going to help you. Drain close to the anus, make a small incision of 5 mm, and if you're going to drain, just drain this much. This is just drainage. That's enough. Why do you want to put your finger inside? Curate is suffice. 13, avoid aggressive manipulation and disruption of loculi, especially with your finger. It just breaks the sensory nerve and the vascular structures which are there. So the patient has paresthesia, they can't feel any sensations, and there's bleeding. So if there's bleeding, you're going to put a lot of pack inside. No packs inside. Drains inside, no packs. Imagine that you have the abscess. Would you like a 6-meter pack inside, or would you like a drain inside which causes no pain? Do not pack abscess cavity injury to anal sphincter. And if you had to pack because of bleeding, do not repack after when the patient comes in the OPD. So the problem with packing is, this is a routine packing for any other abscess in the body, and it will heal. But here you have a connection with the anal canal. So you just, even if this heals, this connection is still there. So packing has no role. Re-exploration and drainage if the fever or cellulitis or signs of sepsis are there. The reason is you missed the deep postanal space, you missed the supralevator, you missed the retrorectal, and these are the causes of recurrence. Hybrid procedure in abscess fistula. Hybrid is waft, laser, fixation, excision of central disease. So this patient had an abscess with opening very high up. Internal opening could not be seen, but some induration could be felt. There was a lot of slimy material which was not coming out with the grasper or even with the forceps. So laser was introduced, the whole tract was burnt, then it was curated, cleaned, and after curating and cleaning, the probe goes to a point. I know that point is there, so I take a drop of methylene blue and touch it. So I know this is the point I have to take out. Now I have to excise the central disease. I keep stressing because if you change this way, complete management of fistula and abscess can occur. So when I take out the internal sphincter opening, I like to do it with laser bare fiber. You don't have it, it's okay, cautery. And remember, when you use cautery, put an infiltrating tube on on it, and just the tip should be exposed. Otherwise, you will have a lot of burns all around. And always infiltrate saline adrenaline and any part which is left behind. So I go and take out all this tissue also. This is part of the problem. Now I put an infiltrating tube inside. It comes from outside. Through that, I'm going to put the fixation device. And the tract which is left behind, I'm going to take that out too. So this is just putting on the fixation device. I'm going across and taking out. That's what comes out afterwards. And just take out the external opening a bit. And after doing that, you're going to manage the internal opening which was there. It's not totally closed. It looks totally closed. You see the fibers, you can see. Now, these were the steps. See the abscess location and see the tract. The tract was going up. So I managed the tract which was going up, and everything was used. Right? This is the healing at 3 weeks. Now, you have to have everything. Fixation, you have bought it once, you have got it there. Laser, you have bought it, just the fibers are there, and fibers are reusable. And after you have bought it, there's nothing which has to be paid for once you bought the machine. You may have to buy a cautery wire after a couple of 100 cases, but that's 17,000. 100 cases, that's 17 rupees or 170 rupees per case. So it's not there. Now you say, why should I do all this? Routinely, if you want to operate this and take the whole thing out, first of all, patient satisfaction. I have patients coming from all over the place, all over the world, simply because they want minimally invasive surgery. They can go to work after a few days. They don't need any major dressings, small dressings are enough. And the amount you get is 10 times what you get for any other case. That's where the difference comes. So it's doctor satisfaction too. Recurrent abscess fistula requiring multiple treatments and non-healing wounds, biopsy. Rule out malignancy. Send pulse and tissue for TB PCR. So if you have anything like this, think of tuberculosis, Crohn's, malignancy, and peritonitis is quite common. You get 1 to 2 patients a month. They come with either fistula with multiple holes all around, or they come with perianal sinus with multiple holes all around. You have to treat that first, and this comes in the end after 6 months. So if you have a retroviral disease, naturally, if the CD count is less than 500, you got to start the retroviral. And when it reaches 500, then you start AKT. AKT you cannot start if the CD count is less than 500. It is going to be very difficult for the patient. So I didn't know this fact, so I'm putting this fact in front of you. In our conference, this came out, and there are many things in the literature. Low CD4 counts, treat that till it becomes 500, and that is the point you start AKT. When in doubt, send for histopathology and TB PCR, and they will heal. When you do have tuberculosis, you start AKT. Do not operate unless abscess is there or you want to take a biopsy. Wait 6 months. Whatever is left, you operate that. Nothing is left, you don't do anything. So, same. And these patients will have a very odd history. The abscess is on top, and there's a secondary opening, and coccyx is painful because it's gone to the coccyx. And if you have MRI like this is the same, this is a different patient, the one I showed you before. I call it's a tubercular signature. MRI reports which does not explain what is going on is a tuberculosis. And naturally, you do TB PCR, tissue PCR, and tissue histopathology. But in post-op, if these were negative and still it continues, discharge continues, do it again. I had one patient, it came positive post-op. So this is healing. So the rules in management of anal abscess: early surgery, minimum incision close to anus, correct drainage site, complete drainage, primary fistulotomy, ceton placement, tubes and catheters. Do not give cruciate incision. Do not break loculi. Do not pack. And do not miss abscess extensions. So as pointed out, we have an instructional course with a degree in AIMS Bhopal. So AIMS ka tappa lagne wala hai. And our conference is in Ahmedabad. We encourage you to come for it. And again, people keep asking me outside, where is the book? Just outside this hall, this book is available. It's on discount, cheaper than what it is at Amazon. Thank you so much.